Good morning, my name's Jo Garraway, and I'm going to be doing a guest lecture this morning for you on behavioural pharmacology. I just want to start by saying thank you to Dr. Lisa Riley for her very kind invitation to speak with you this morning. And I really hope that by the end of this morning's lesson that you will all have a bit more of an understanding of behavioural pharmacology. It might not be a subject you have spent much time thinking about necessarily, or it might not be something that you're particularly familiar with. So I hope that, as I say, by the end of the lesson that we'll all be a little bit more familiar with it. So in terms of what we're going to have a look at, we're going to spend some time looking at the actual definitions of pharmacology, and then break it down into a little bit more detail, looking at processes of pharmacodynamics and pharmacokinetics. So pharmacodynamics, as we're going to come on to, is the action of the drug in the body, the effect that it has, potentially the therapeutic effect, or I should probably say hopefully the therapeutic effect that it exerts, but also how this opens the drug up to potential side effects. And then we're going to move on and talk about pharmacokinetics, which is basically what the body does and how it processes the drug in order to initially get the therapeutic effect, but also to allow the body to process it effectively and ultimately excrete it. We're then going to move on to look at psychopharmacology, which is the use of drugs specifically in behavioural modification, where we can use medications to change or enhance an animal's mood or demeanour. And sometimes this is deemed as an appropriate response to behaviours deemed undesirable by owners, or behaviours that are deemed problematic for public safety or human safety. And then we're going to spend a bit of time talking about the use of psychopharmacology specifically in behavioural management, and just spend a little bit of time talking about potential ethical considerations or ethical implications. So before we go any further, I just wanted to introduce myself. As I said before, my name is Jo Garraway, and I appreciate it's a little bit strange not being able to see me this morning. I do apologise for that. But as you can see from my credentials, my background is very much in veterinary nursing. So I became an RCVS registered veterinary nurse in 2008, and spent a significant chunk of time working in small animal practice. So doing, as you would expect, lots and lots of veterinary nursing. And to start with, it was lots of a mixture of surgical and medical nursing, as well as consultations and patient care. And then in 2015, I achieved my RCVS Advanced Veterinary Nurse Diploma. And at that time, I chose to specialise in critical care and medical nursing. So, as I said before, I teach at University Centre Sparsholt. I'm the course tutor in the Veterinary Nursing Foundation degree. And my interest in critical care nursing does allow me to kind of sit in both camps. So alongside in my free time, basically, which I appreciate you're probably thinking, has she got free time? I do, I can promise. In my free time, I also work as an emergency and critical care nurse. So it really gives me the chance to both develop my academic side, and also develop my nursing skills, which I have to say I still very much love being a veterinary nurse. And as you can see there, I recently completed my MSc in animal welfare science, ethics and law. So that's obviously something else that's opened up a whole remit of discussion around animal welfare and our approach to animal behaviour specifically. So I suppose the first question really, whenever we talk about pharmacology, is that we have an understanding of what we're actually referring to. Now, if I was with you in person, this would be the point that I'd ask you to write down a definition. I would still encourage you to take a few minutes just to have a think about how you would define pharmacology. I won't leave too much silence, but just have a think about it. So, in terms of what the definition is, I say I'm not too sure what you wrote. But basically, pharmacology can be defined as the study of medication. Now, In some ways, that's a very simplistic definition, and certainly sometimes we can forget the complexity of pharmacology, in the sense that, we give a medication to an animal, or certainly to ourselves. I don't know, maybe you have a headache and you take an ibuprofen, and let's say within half an hour, 45 minutes, your headache is gone. And now that does demonstrate pharmacology, but if we take it a little bit more detail, and a slightly more sophisticated approach to pharmacology, what we're actually observing is the relationship between the dose of the drug and the clinically observed pharmacological effect. Now, again, we can simplify this as simply the study of drug action. And with every medication, there are kind of three areas or three potential effects that we can observe. So the first of these is the therapeutic effect. So this is where we have a recognised clinical concern, and we give a medication in the hope of either alleviating or inhibiting the observed clinical sign that we see. Now, in most drugs, this is known, it's predictable, it's certainly been tested quite extensively, and it has received a license, or a verification, basically, that that specific drug is going to have the observed therapeutic effect that we're desiring. Now, for some medications, we also get side effects. So side effects would be known effects that can occur, but they're not specific to the body system or the species that we are expecting. So give you an example, potentially we have let's say we've got a Labrador that has arthritis. Unfortunately, lots of Labradors have arthritis, and the veterinary surgeon, not myself as a nurse, but the veterinary surgeon prescribes a non-steroidal anti-inflammatory. So the therapeutic effect for that medication would hopefully be analgesia. We would suspect that there would be some level of anti-inflammatory. That would very much be the therapeutic effect. However, and unfortunately this does happen, we also know that side effects for particular non-steroidal anti-inflammatories may well be diarrhea and vomiting. Now, it's predictable, it's certainly not unheard of, but it's not the effect that we're looking for. So that would be the side effect, and that's basically where there is an interaction or a relationship between the dose of the drug and other possible effects within the body. And then the third category is an adverse effect. So these are unpredictable, very, very rare, quite haphazard, to be honest, but it's where the body reacts quite adversely, as the name suggests, to the medication we've seen. So you might see an allergic reaction, for example. You might find that your animal violently vomits. You might find that they're covered in hives, for example. So again, there is documents to suggest it can happen, but it's very, very unpredictable. So within our pharmacology, we can take all of that and simplify it into two clear areas. So the first one is pharmacokinetics, and the second one is pharmacodynamics. So what we're going to do is spend a bit of time now and go through these in a bit more detail. So first question then is, what's pharmacodynamics? And basically what it is it's the effect the drug has on the body. Again, sounds very, very simplistic, but basically it's the initial consequence from the drug entering the body and interacting to the final drug effect that we see. And depending upon the medication and depending upon the route of medication that we're giving will determine the level or the extent of consequence that we observe. As we said before, our primary or our initial observation that we're aiming for is the therapeutic effect. So in order to have a therapeutic effect, every drug works within a specific therapeutic range, which is basically the concentration that is required within the body for the drug to be able to exert the effect that we are anticipating. So in order to have an effective pharmacodynamic interaction, the drug has to reach a specific concentration and remain at that concentration for the time span that we are hoping the therapeutic effect to be presenting. And that's when we decide whether we have a desirable or an undesirable effect that we're. So the majority of our drugs that we use work on what's called a receptor-mediated pharmacodynamic process, which basically means that in order to have any kind of effect, or in order to exert its therapeutic effect, the drug has to interact on a molecular level with a receptor site. Now, the receptor sites themselves are predominantly made of protein. There are a few extra kind of ligand bonds in there, but predominantly they're proteins that sit on the outside of the cell membrane. And each of these receptors is very, very specific. So the body has basically evolved to have differentiated proteins on the surface, and each of those kind of different shapes and different structures have the potential to interact with different types of molecules. In this instance, it's medication. So we've got a nice picture here for you, just shows a couple of different interactions. Now it's worth saying that not all of these are drug exerted interactions, but basically what the body has is various different levels of receptors on the outside of the cell membrane. And if you can remember from probably GCSE or A level, if you did A level biology, is that animal cells are covered with a phospholipid bilayer. So this is our purple section here. And on the outside, we have our lipid or our fat. And then on the inside, we've got our phospholipids tails that come together. So that creates a semi-permeable membrane. So not all materials can pass through it. And actually, realistically, what we find is only substances that are of a lipid or fat-based substance have the ability to cross over. Because this cell membrane is very, very specific in that it's only accepting of substances that are similar to itself. So the fact that this membrane is made predominantly of fats determines that actually only molecules that are also made of predominantly fat can pass through it. Now, not all of our drugs are predominantly fat-based. In fact, there's quite a lot that aren't. So in order to be able to exert an effect, we find that receptors sit on the outside of the membrane, away from that phospholipid, and it allows for them to have an effect as required. So in this instance, for example, this first one, we've got the molecule comes and sits on receptors on the very corner of kind of our purple splodge. It's a very technical word there for you. And what it does is it opens up the channel and allows movement of other molecules through the channel. So it's almost the equivalent of opening up an extra lane of traffic on the M27 on those awful days when there's so much traffic. And we're all a bit chocker. And basically what it does is it allows for substances to move across. We've then also got the instance where on the second picture is where we have a what's called an enzyme linked receptor. So again, the molecule comes and sits on the receptor, but what it does is it activates an enzyme at the other side of the cell, so it activates in a different way. The G protein coupled receptors, again, don't need to worry too much about that, but what we have here is a receptor on the outside that encourages the activation or the coupling of another molecule within the cell itself. Or we've got this one, which basically has the ability to move through the cell membrane, but then activates a receptor on the other side. So whatever function we see, the key thing is that the molecules from the drug themselves are causing a reaction. And as I said, in this specific instance, they require a receptor to be able to do that. So another couple of pictures for you. So here we have our noradrenaline receptor, and hopefully noradrenaline is something that you have heard of before, and hopefully you know that it's a neurotransmitter, so it activates neurological signaling, which is obviously really important when we're trying to describe behaviour or observe behaviour, particularly if it's a neurologically or a nervous stimulated behaviour. And what we've got here is actually a molecule that is blocking the action, so we'll come back to that shortly, but similar kind of principle. We've got a receptor that acts almost like a landing strip for molecules to come in and interact with. Again, we've got a sodium channel here and a potassium channel, and a couple of other bits going on, but the key thing to remember is not all molecules can pass through this cell membrane, so that's why we need there to be some receptor interaction. So once the drug molecule comes into contact with the receptor, there are a number of different responses that we can anticipate. And what these responses come down to is how the drug molecule itself sits within the receptor, and particularly whether it's supposed to be there. So these can be described by three different types. So the first is known as a full agonist. And this is where the drug molecule itself fits almost perfectly, or actually perfectly, with the receptor site. So it's the equivalent of putting a round peg in a round hole, or a square peg in a square hole. The drug is designed to fit in that receptor, and as a result, it comes into contact with all of the biologically active parts of that receptor. And the way that we can interpret this is with our therapeutic effect, we get a full or maximal biological response. So a drug example of this would be something like methadone, which is a highly potent analgesic or highly potent pain relief. And the way that methadone works is it can fully exert its effect on the receptor because it fits perfectly with the shape or the structure of that specific protein. Now, the second type is known as a partial agonist. So this is where the drug molecule can sit in the receptor and has the potential to cause an effect, but it's not the precise size or the precise shape that is suitable for that receptor. So to give you an analogy, it would be the equivalent of you putting on a pair of shoes that maybe were one size too big or one size too small. They still function as shoes, they still provide some comfort, but they're not quite right. It's like putting on, and again, this is very stereotypical, but that pretty pair of heels, and maybe they slip when you walk in them. So they function as a shoe, and equally in our drug receptor, the receptor functions. The drug is able to exert its effect to generate a therapeutic effect, but it's partial in comparison to that of the maximum. So it will behave similar. So, for example, we have a drug in practice that we use, which is buprenorphine, which is again a very similar kind of category of medication to methadone. It's also an opioid, and it actually shares the same receptor as methadone, so it behaves in a very similar way. But whereas methadone gives a very strong, very potent analgesic effect, buprenorphine, let's say, is like 2/3 the effect. So it behaves as an analgesic, but it's not quite so strong, and it doesn't give that full biological response. The third category is a little bit different. So this is known as an antagonist. And this is when you get a drug molecule that can fit in a receptor but has no biological ability to activate it. So it's very much a space invader, and it can basically sit within that receptor site and fill the receptor, but it doesn't activate it. It doesn't cause a biological response. So the role of an antagonist is to provide a receptor blockage, or to inhibit the response of another molecule that is coming into contact that does want to use that receptor site. And often what we use antagonists for is when we are trying to prevent the occurrence of a naturally occurring interaction. So one example that would be quite common would be in the use of anesthetics, and what we tend to do is we would give a drug that would inhibit the receptor site required for neurotransmission. So because the neurotransmitter is inhibited, say for example the receptor that it activates the adrenaline or the noradrenaline response that we see in the neurological system, because that drug is sat in that molecule, noradrenaline or adrenaline is unable to perform its normal function. So therefore our patient appears lethargic or sedated, or even completely asleep, because the normal mechanisms that are required to perform that response are inhibited. To kind of put it in a different perspective for you, we've got some images, and just to kind of summarize it. So again, with our full agonists, apologies on the pictures, I realize it's not quite a round hole for a round shape, but hopefully you get the meaning. So our full agonist comes into contact with the receptor, is fully in contact with all of the biologically active parts of the receptor, and therefore the response that we see, or the therapeutic response that we see, is the maximum biological level it can be. Our therapeutic effect is highly potent, highly effective, and that would be our full agonist. Whereas with our partial agonist, and obviously we've got a bit of complication here with another molecule coming in, but the partial agonist is as I say, 2/3 correct. It's going to generate a response. It can fit quite comfortably in that receptor, but it's not that perfect fit. So therefore, not all of the aspects of the biologically active part of the molecule are in contact with the receptor. And as a result, we get a response that is very familiar. It's quite like the full agonist, but it's not quite as potent and not quite as powerful. And then the third, as we said, is the antagonist, which is our space invader. And as you can see from the image, it really shouldn't be there, but it can slot into to that seat, and therefore it prevents the interaction of any other molecules whilst it's sat in the receptor. And as I say, there is a therapeutic need for antagonists because what it allows us to do is either inhibit natural processes or actually reverse other drugs that we've given. So the way that we have to consider the principle of affinity. Now, affinity is where drugs are given together and they compete for the same receptor site. Because unfortunately, as much as the body is brilliant, what it hasn't done is evolve to every type of medication that we have generated and that we give to animals. So we do find that some drugs share the same receptor type. And therefore, if we give them together, what we find is the principle of affinity takes hold. And what affinity is, it's basically how attracted a specific drug is to a specific receptor site. And if that attraction is really, really great, then what you will find is that specific drug molecule will outcompete every other molecule which is trying to get into that receptor site. And basically the rule is that the drug with the greatest affinity will win. Now, from a therapeutic effect, initially this creates a bit of a concern, particularly if you're trying to give a drug or trying to give two drugs that share a receptor site, because what you're actively doing is encouraging competition. And unfortunately, you will find that one of the drugs, the drug with less affinity, will be outcompeted, and therefore the therapeutic effect that we're requiring from that drug won't have any potential effect at all. But also we've got a clinical situation where sometimes we actively use drugs that compete for the same receptor in the hope of reversing the initial drug effect that we've encouraged. So a really nice example of this is when we use medetomidine and torbagezic in practice, which combined together give a really stable sedation. We use it in cats and dogs specifically. And what we can do with this sedation is we have the potential to reverse the effects completely once whatever procedure we required sedation for has finished. And the way we can do this is we use a drug called antecedin, which basically will outcompete medetomidine for the same receptor site. So we've given medetomidine and it goes off and finds its own receptor, sits on the receptor, forces the animal to go to sleep. But then what happens if we then administer antecedin? What we find is antecedin will outcompete medetomidine, so it has a much greater affinity from the receptor site that they share. So basically what Atipan will do is antecedin, I keep switching between the generic and the active, I'm very sorry. But basically what antecedin will do is the molecule will come in, recognise that medetomidine is on the receptor site and forces the medetomidine off the receptor site. So the therapeutic effect of the medetomidine is instantly cancelled out. And what that means for us in clinic, it means that we have an animal that we can then fully wake up again. And the therapeutic effects of that sedation are completely removed. So obviously that's quite a positive response to this kind of principle. The challenge is, though, is that drugs that have a weaker affinity tend to also have a weaker therapeutic effect because, as we said to start with, all of our drugs work at specific concentrations, and in order to have the strength of therapeutic effect we're looking for, we have to be able to establish that concentration. And basically, the longer that concentration is established for, the longer the therapeutic effect will be seen. And what we sometimes find, if drugs have a lower affinity for particular receptors, it's the equivalent that they just get bored. So they sit on the receptor site, they have the therapeutic effect, but because they're not particularly attracted to that receptor or relatively less interested in that receptor, you find that they then disappear off the receptor. And once they've moved off, the therapeutic effect is stopped. So sometimes what we find with drugs that have lower affinity, we basically need to either give a higher concentration to hope that there's a longer lasting effect, or we have to repeat dose that patient to make sure that the therapeutic effect is established for the period of time that it's required. So a couple of other bits of terminology that are worth knowing, and again this is to do with how a drug interacts at a receptor site. The first one is specificity. So specificity is how wide a range the drug has in terms of its receptors that it can work on. Now, as we said before, with our drugs we know that they have the therapeutic effect, which is our desirable effect, but equally we've said that there can be side effects that can occur. And often the side effects occur because the drug that we've used has an affinity for a number of different molecules, a number of different receptors around the body. So what we want to be able to do is deter that drug by encouraging it to go to a very small range of receptors. And as soon as it goes to a smaller range of receptors, it's going to increase the safety and lower the side effects of that medication. Now, unfortunately, we can't deter drugs. That's not how they work. They, funnily enough, don't have conscious thought. So what we try and do is use a drug that we know has a low specificity rather than a drug that has a really, really high range or a larger range of receptors that it can interact with, because that increases the safety for our patients, but also helps to reduce the likelihood of secondary conditions occurring, which from a companion species point of view also tends to keep our owners much happier and much more compliant, because certainly if we give one medication to treat one condition and we send them home, and then within a few hours we find they start doing something else which is undesirable, as you can appreciate, that doesn't really go down very well with our owners. But from a safety point of view, a low specificity is also advantageous. So the next term is potency, and this is how much drug is required to present a therapeutic effect. So again, a similar kind of theme as specificity, that potency is as important, because we don't want to just keep overloading our patients with unnecessary medication, because again, any extra medication that's circulating in the animal's cardiovascular system has the potential to create toxicity. It also generates more waste. It will require more energy to excrete it, and as we said before, the more drug that's available, potentially it could move off and use different receptors. So what we want is a drug that is highly potent, which means we only need to have a very, very low concentration in order to have a therapeutic effect. And again, what we tend to find is drugs that have a high potency also tend to have a much more exaggerated therapeutic effect. So they're overall much more efficient in what they do, and again, increase the safety. So the final term is efficacy. And efficacy is the drug's own ability to produce a therapeutic effect. So it's quite similar to potency, in that potency is the amount of drug, and you can assume that if a drug doesn't need to give much, if you don't need to give much of a drug in order to get an effect, then you can assume that the drug also has a very good ability to produce a therapeutic effect. But that's not always the case, because what we sometimes find is a drug can generate a therapeutic effect, and only a little amount needs to be given, but potentially that therapeutic effect is very short-lived. Maybe it causes a number of side effects. Maybe it's intermittent therapeutic effect. So efficacy is how good it is at giving the therapeutic effect. And actually we might have to give quite a lot of a drug to be effective, but once we've given that dose, it's a sustained, predictable and reliable therapeutic effect. So that's where you would have the difference between the two. So the other thing that is quite interesting when we use medications, and if we're aware of how they interact at receptors, is we can also predict how they interact with each other. And this is known as a drug interaction. And basically a drug interaction is any time one drug works and has an effect or affects the activity of another drug when they're given together. So this can occur at any stage, and we're going to go through pharmacokinetics in the next section. But what we tend to find is you might find that a drug has an increased absorption, when it's given with something else. We might find that a drug has an increased effect at the point of metabolism. We might find that it has an increased effect when it's distributed. So it can happen at any stage, but the important thing that we need to be mindful of is that we know at which stage the intensity is presented, and also whether this is an encouraging or an advantageous event, or whether it's a disadvantageous event. So the key thing with drug interactions is, in order for them to be administered safely together, or certainly for us to use drugs at similar times, is generally drug interactions are predictable. But there are always those opportunities for chance, and things change. And in terms of medication, what we tend to find is the most predictable reasons for change is the route of administration and the specific patient. Now, depending on species, depending on age, depending on disease status, we might find that an animal is more predisposed to a specific drug interaction occurring because of their physiology or because of their metabolism. So, for example, a patient that has renal disease, which would lead to them having poor ability to filter and poor kidney function, has a greater risk of drug interaction at the point of excretion if both drugs are excreted via the route of the kidneys. So it's about us looking at the medication and establishing what the risks are, basically almost doing a risk assessment before we give the medication. And going from there. And anything that is deemed harmful is immediately considered as an adverse reaction. And professionally, for us as veterinary nurses and veterinary surgeons, we are obliged through our code of professional conduct to report any adverse reactions. So we therefore should be using drugs in a very conscientious and very careful way to try and avoid these harmful effects and these adverse reactions. Having said that, there are a number of interactions that are a positive thing, which we certainly use for the benefit of the patient. And the first of these is a summation. So this is where the drugs interact together, but you don't necessarily see any change to that specific drug. So the response is equal to the combined responses. So for example, if I'm giving a sedation and I'm giving an analgesic, rather than interacting adversely with each other, what we find is the medication that's providing the analgesic will provide the analgesic, and the medication that provides the sedative will provide the sedative. But in comparison, rather than our patient just appearing to be pain-free, they're also asleep. So you get the benefit of both medications, and they work together and they complement each other. The next one is a synergism. So this is where the response of the two drugs together is greater than the combined response of the individual drug. Now this is where I get a little bit geeky, but imagine this as your, and again it's going to show my age, but as a child, I used to watch the Power Rangers. I know, I'm so cool. But this would be the equivalent of your kind of Mighty Morphing Power Ranger. So individually, all the Power Rangers were pretty good. But when they came together, they made that kind of weird monster that could basically destroy any other monster. And that's kind of what we see with a synergism, is you've got a drug by itself that has a significant value, that has a positive therapeutic effect, and you've got other drugs that you put with it that generate a slightly greater effect. So to give you an example, we mentioned before about medetomidine and torbagesic, and the two together are a really quite stable sedative. But we also have ketamine, which I don't know how much you know about ketamine, hopefully, not too much personally. But what ketamine is it's known as a dissociative anesthetic. And what it does is it doesn't necessarily put the animal into a sleep state, but what it does is it changes its perception and basically makes everything around it seem out of its normal perspective. So the animal is less responsive to its environment, and it's less able to perceive what sensory information is being received. So it's a good medication to use in the sense that by itself it allows our patient to lose awareness, to lose inhibition. But when we put it with the medetomidine and the torbagesic, the three medications together create a general anaesthetic state. So by themselves, torbagesic and medetomidine give us a sedative. And in terms of consent in clinical practice, we would be requesting a sedative. So if we were to make a lot of noise, if we were to stimulate our patient, we would expect them to show some kind of responsiveness. However, when we mix ketamine into the mix, the ketamine synergizes the the analgesic and the sedative qualities of those individual drugs and makes the whole combination a general anaesthetic. So our patient is pretty much sound asleep, but also has muscle relaxation, is unable to perceive its environment, and also has analgesia. So the combination of everything together gives us a superior drug response, which we wouldn't have got had we given everything individually. And then the last one is a potiation. So this is where we take a drug that is completely inactive and it enhances the effects of another drug. Now, there's not many instances where we do this, but for example, potentially we could give something like when we give antibiotics, for example, to our gastro patients, we also give a medication that speeds up peristalsis. Now, that's not the reason that we give it, but what we find is the two together give a really effective antimicrobial action, because you've got a medication that isn't an antibiotic combined with another one, and the two together create this really effective drug response. So it would normally be at this stage that I'd ask the class if anybody had any questions, but obviously under the circumstances that isn't possible today. But what I will do is leave my email address with Lisa, and I'm more than happy for her to share it with you. So if you do have any questions, please do contact me. Equally, if you want to know a little bit more or have further reading, then again, drop me an email, and I'm sure I can try and assist you. If I don't know the answer, I certainly have colleagues that will, so we can certainly find out answers for you. So we've discussed pharmacodynamics, which, as we said, is only half of pharmacology. So the second half is pharmacokinetics. And pharmacokinetics is ever so slightly different in that whilst dynamics is looking at what the drug does when it's at a cellular level, so how it interacts with the receptor, how it causes its therapeutic effect, what kinetics is the study of the drug within the body, and specifically how the body responds to that drug. So what it does from the point of administration to the point of excretion, and everything in between. So when we talk about pharmacokinetics, or the mechanisms of pharmacokinetics, there's a couple of other areas that we are interested in. So the first is the duration of the effect, and this is really, really important that we have an understanding of this, because to allow us to have a responsible approach to medication, we firstly need to know what effect it's going to have, but equally how long it's going to affect our patient. And from a therapeutic effect, we obviously want to be able to know that if the time span, because that's going to determine whether or not it's a suitable medication. For example, if we need our patient to be sedated for half an hour and the medication is going to keep them asleep for 8 hours, it's probably not the medication we're going to select. The next one is biotransformation. So this is what the body does to the medication, potentially before it reached the target site, but majority of time is what it does afterwards. So once the medication has become ineffective or has become less useful, the body will then transform it and process it into a substance that it can then excrete. Obviously, effects is important. Again, as we said before, we need to know this before we administer a medication, to make sure that we can give a medication safely and that it's fit for purpose. But also from a professional point of view, all of our companion species specifically, but actually all animals, do have an owner, or at least somebody who has duty of care over that animal. So we also need to be in a position where we can describe those effects to whoever is responsible in order to get consent, and not just consent, not just like, yeah, go for it, but informed consent, so that owners are fully aware of the effects, they're fully aware of the risks, they're fully aware of potentially any complications, and therefore they can say yes with full understanding of what they are allowing their animal to go through. And then the last one is route of excretion. So excuse me, how the drug is changed in order for the body to be able to process it and ultimately eliminate it. So, as we said, pharmacokinetics examines drug movement, and this is broken down into four main categories. So, the first is absorption, the second is distribution, the third is metabolism, and the fourth is elimination. And we're going to chat through all of these individually. But the key thing to remember is not all drugs behave in the same way. And whenever we refer to pharmacokinetics, there are the three kind of influences that we always need to consider. So the first of these is the route of administration. And we know that some medications, because of their route, will have a delayed absorption. So therefore the therapeutic effects that we are requiring will also be slightly delayed. Equally, we've got some very immediate routes that we can choose. For example, some intravenous administration, where the medication is sent directly into the blood supply. So the therapeutic effect and the time it takes for the molecules to get to the receptor is very, very short. So that's obviously going to affect the subsequent movement of that drug in that patient. We also want to think about disease status, and this is effective at various different points of the pharmacokinetics, and we'll come on to those individually in a minute. But for example, if our patient is having to eliminate its drug via a system, for example, the kidneys or the renal system, that we know there is significant deterioration due to disease status, then again, it's something that we can predict, and potentially it's going to change the medication that we select. And then the last one is the drug formulation. So actually what is contained in the medication, what is the active ingredient, what dosages is it, is it a particularly high dose, is it a low dose, how long does it take to be eliminated, what's its elimination rate, for example. These are all things that are going to be of interest to us. Okay, so let's start at the beginning then. So we give our medication and we expect there to be a response. And the way the body does this is we start off with our administration route. So there's lots of different administration routes that we can use, and hopefully you, if I asked you, you'd be able to give me a few. But for example, there's things like oral medication. We could give things subcutaneously, which is under the skin. We could give things into the muscle, which would be intramuscular. As we've already said, intravenous, which is into the vein. Potentially, we're going to give things by rubbing it onto the skin, which would be a topical administration. But regardless of the route, the key thing is that the drug has to get into the blood supply and it has to be absorbed. So the only one that we exclude here would be intravenous, because as we said, this goes directly into the blood supply, so we don't need to get over that barrier. But everything else has to be absorbed, and it has to make its way to the blood supply to have an effect. Once it's done that, it then gets distributed into the body fluids and into the tissue. And as we said before, all drugs work at specific concentrations. So again, this is going to present some delay. It's proportionally short for our very quick acting medications. But the key thing to remember is medications will only have a therapeutic effect once they've reached that specific concentration. So for yourselves, for example, maybe you've woken up with a headache and you decide, do you know what, I don't want to take much medication today, but I want to take something. So instead of taking the 2 ibuprofen that are prescribed on the packet, you decide to take 1 ibuprofen. Now, whilst in some ways we could argue that will have an effect, it's not the specific concentration that's required to cure your pain, to alleviate your pain. So that's the reason why sometimes you might have to take another ibuprofen, or wait a few hours and take the full dose, because taking 1 single tablet is not going to reach the concentration that's required. So therefore you're not going to get the therapeutic effect that you're looking for. And as we said before, this concentration needs to be established at a specific target site for a specific period of time. And as we said before, that is defined as the therapeutic effect. So it's all very specific, it's all very controlled. It's not that we give a medication and hope it gets there. The concentration has to be given at a dose in a formula that we know is going to get to the target site. Once the drug has reached its target site, it then has its therapeutic effect. So that's then where pharmacodynamics comes into effect. And as we said, it's the interaction between the drug molecule and the receptor. Whether that is an agonistic or an antagonistic effect will depend on the medication. But once the medication has had its effect, once it's lost its affinity for the particular receptor site, it will basically fall off and go back into circulation. So at this stage, the drug has to be inactivated because it remains biologically active. And if the body didn't inactivate it, it wouldn't be able to be eliminated and it could potentially cause toxicity. So the medication goes through a stage of metabolism, becomes inactivated, and basically the body changes it into a format that is dissimilar from the original product that was absorbed. And then it's eliminated. So that occurs through metabolism and then excretion. And as we said before, in order to exert our therapeutic effect, our plasma concentration has to be established, and depending upon the onset of the medication, the intensity of the medication itself, and the duration that it occurs for will determine the therapeutic effect that we witness. So as we mentioned, in order for a drug to have a therapeutic effect, it must reach a certain concentration. And this concentration starts from the point of administration and when it gets absorbed into the blood supply. And this can be plotted against time. So as you can see here, we've got a bell-shaped curve, and from the point of administration, the body starts to absorb that medication. Depending on the route, it will determine how quickly it absorbs it. But as it does, the drug will slowly start to go through, follow through, distributed through to the target site. And once it's at the target site, it will build in concentration, and time obviously increases as well. So we eventually reach a point of a maximum or a peak drug concentration, which is at the point at which we would see a therapeutic effect. And as you can see on our graph, it's where they meet up in the two. So we've got our plasma drug concentration and our time, and that would be deemed as our optimum drug concentration, and hopefully, if our concentration is correct, the point at which we would see the start of our therapeutic effect. Now, the key thing to remember is that therapeutic effect will only last for as long as that medication is at its peak drug concentration. So as you can see from the graph, it's starting to drop off over time, so therefore our effect is also going to be affected. Now, as we mentioned previously in the last slide, the drug's concentration itself has a really significant role in this and correlates really specifically with the onset of the therapeutic effect, but equally the distribution route would have a significant impact to that, the intensity of the therapeutic effect that we see, and the duration. So with all of that in mind, at this stage we also need to consider a principle known as bioavailability. And what bioavailability is basically it determines how much of the drug that we have given the animal reaches the circulation or reaches the target site specifically unaltered. So as we said, all of our medications work at specific concentrations, and that concentration is non-negotiable. So we have a certain concentration that must reach the receptor or must reach the target site in order to have the therapeutic effect. So what we need to be aware of is how that is affected, or how the route of administration or how the species affects the bioavailability of the medication that we're giving. So bioavailability is affected by the rate at which the drug is absorbed, and also how easy it is to absorb. Now, depending upon the route that we decide, some medications are more subjected or more susceptible to increased absorption compared to others. So one example of this would be oral medications, which in order to get into circulation have to go through the alimentary or the gastrointestinal tract. And one of the key areas that it's going to come in contact with almost immediately is the stomach. And we know that the stomach is full of stomach acid, and by its very nature, it's designed to be corrosive. It's designed to break up organic matter. So this initially presents us with quite a significant challenge, particularly if we have quite a sensitive medication. So again, we'll be thinking about the type of routes that we're choosing, potentially the type of medications we're choosing. And if we don't have an option, then we need to make sure we give a much greater concentration to almost allow for that excess to be burnt off by the stomach acid. So if a drug reaches circulation completely unaltered, it's given a percentage of 100% bioavailability, and we work down from there. So depending on how much of the medication or what proportion of the medication reaches circulation would be how we determine bioavailability. But basically what it is, as we said, is a combination of the rate of absorption or the ease of absorption and how much of it is actually absorbed before it gets to the target site. So why is that interesting? Well, the main reason is because, as we said, in order for every medication to have an effect, unless it is, we've got 3 that don't require it, which are very specific. We don't really talk about them, but the majority of medications must get into circulation. So at this point, we consider the principles of distribution, and distribution is basically how the drug moves from the site of absorption or site of administration into the circulation. And as we said, every drug has a specific target tissue. In some cases, we have the slightly more gregarious drugs, let's call them, that have more than one receptor that they can work on. But the key thing to remember is our pharmacodynamics. So where we have a really specific receptor that can interact with the specific drug molecule. So it's non-negotiable, but the way in which our drug gets into circulation, unless it's an IV medication, can exist in 2 forms. So the first is a bound medication. So this is where you've got molecules that are unable to reach the target site by themselves. Now this could be because of their structure. It could be that where they're going, the target organ that they're traveling to is inhospitable to them. Potentially their structure is repellent of the local, the surrounding tissues, and we'll come on to what we mean by that in a second. But the key thing is that the drug cannot get there by itself. So in these instances, it has to bind itself to a plasma protein that's in circulation, and then the plasma protein takes it to the target site. So to give you an analogy, it's the difference between catching the tube and going across central London, or deciding to try and walk across, let's say, Piccadilly Circus, for example. So it's much, much safer, it's much more efficient for those particular drugs to use plasma proteins. The one tricksy side of it is that once you get to the target site, the plasma protein has to give back the drug molecules. So we do find, whilst it increases the efficiency of these specific drugs to get to the target site, we do have a bit of a time delay because the plasma protein ultimately has to offload the drug molecule that it's taken on board. So the other category we have are unbound drugs, and these are drugs that have the ability to move across membranes, to be absorbed, to be distributed by themselves without the need for a plasma protein. So these are generally seen as much more time efficient because there isn't the delay that we recognise in the presence of the plasma protein. And the important thing to remember is all drugs have to be unbound. They all have to be free in order to be able to interact with a receptor. Because as we said, the receptor is specifically shaped, or as specific as possible, shaped to the drug molecule itself. So it's not designed to attract or work with the plasma protein, because if it did, we'd have lots of random reactions all over the body. So whatever form, whatever transportation method the drug uses, it has to be unbound, it has to be free to be able to interact with the receptor. And as we've already said, once that interaction occurs, then we can consider pharmacodynamics and all the principles that we've already discussed. So the other thing that is of interest to us is the kind of physical appearance or the physical properties of the drug. And basically what it will allow us to determine is what type of substance the medication is able to dissolve into. And again, depending upon the preference of the drug will determine the kind of substances and particularly the type of areas that that drug can go into. So broadly speaking, we can split it into two different categories. So we've got hydrophilic and lipophilic. So philic as a suffix means preference for or love for. So looking at the prefix, hydrophilic is water loving, so therefore it can be dissolved into water, and lipophilic is fat loving, so it can be dissolved into fat. Now, depending on the route that you are administering, some medications will actually use the cell membrane. And if you can remember from potentially GCSE, maybe A-level biology, animal cells are covered in a phospholipid bilayer. Which basically is predominantly or nearly all made of fat. So if we have a drug that is able to dissolve in fat, it means that it can cross straight into the cell through the cell membrane because it's the same material. Whereas if a hydrophilic medication tries to do that, it's repelled because hydrophilic drugs are also lipid phobic. Equally, lipid-philic drugs are also hydrophobic. So we find that there is a direct contrast between these two different medications. So if we have something that is hydrophilic, it must be dissolved in water first before the body can use it. So, for example, our oral medications tend to be, not all of them, but tend to be, a lot of them anyway, tend to be hydrophilic. So it has to use an alternative route to be able to be absorbed. So in this instance, it goes to the hepatic portal circulation, and blood is predominantly made up of water-based material. So therefore the drugs can be dissolved in the water because they are hydrophilic, but again that's going to present some time delay in the distribution approach. Equally, drugs that are IM and IV tend to be a mixture, but what they tend to do is diffuse into the extracellular fluid. So again, we tend to require our medications to have a hydrophilic ability to be able to cross over straight into extra fluid. So I've got a picture here for you just to kind of give you some idea. So again, there's lots of ways around it. It's not that water soluble molecules don't have the ability, or hydrophilic molecules can't enter the cell membrane, but they have to use an alternative route. So here we've got our plasma membrane, which as we said is a phospholipid bilayer, and again you've got the heads and the tails. So what we find is that fat soluble molecules can move through, they can pass through that material absolutely fine, no questions, whereas our water soluble may have to use a plasma protein, may have to actually use a channel protein in the structure, or might have to find an alternative route. So again, it's just something else to consider. So once we have reached our distribution site, once we've reached our target organ, what we then need to consider is the therapeutic range. And as we said before, the therapeutic range exists around the concentration that is required to or the concentration that's required to cause a therapeutic effect that we're looking for. But as we said before, it's this optimal amount. So it's always tracked against time. And as we know, not all drugs have the same potency or have the same affinity. So it is subject to other factors. But basically what we need to assess is what concentration we need to establish in order for the drug to be able to have the most effective therapeutic effect possible. But having said that, we want to try and limit the risk of non-effectiveness, which would basically be where we give a medication and we don't get a therapeutic effect, or we get a very short-lived therapeutic effect that is simply not fit for purpose. So to give you an example, it would be, for example, if we've got a half an hour surgical procedure to perform and we've selected an anaesthetic and the anaesthetic only keeps our patient asleep for 10 minutes, that would be non-effective. The other risk is we don't want to give too much medication because quite a few of the medications we use, as we said, have got side effects, and given at really high concentrations also have a significant risk of causing toxicity to the animal. So we're working in the kind of balance between these two. So when we consider this, we've got two different areas that are of interest to us. So the first is known as the minimum effective concentration. And this is quite similar to potency in the respect that potency is the amount the drug needs to have a therapeutic effect. And a minimum concentration is the lowest level possible that we can give that will result in the therapeutic effect. So commonly, highly potent drugs often will have a low minimum effective concentration. And that means that we can give our drugs really, really safely, knowing that we're going to have a therapeutic effect without causing the risk of having excess medication around. Because as we said, excessive medication always presents the risk of toxicity. But depending on the potency of the drug and the side effects of the drug will determine actually how much risk we have. So the other principle that we can apply is the maximum safe concentration, which is basically how much, what is our maximum dose that we can give our patient, which will still give a therapeutic effect that won't result in toxicity. So the other term we can look here is our minimum toxic concentration. Same principle, how much can we give, or how little do we need to give to start causing toxicity to our patient? And really what you want to have is a nice big gap between your minimum effective concentration and your minimum toxic concentration, because it means you've got quite a lot of wriggle room. Unfortunately, there are some medications that have quite a high or relatively high minimum effective concentration, but they also have a relatively low toxic concentration, which basically means when it comes to prescribing and dosing our patients, we have to be really, really accurate, because there's a really high chance, again, we weigh our patients, we make sure we calculate things really carefully, but because there's a close proximity between the minimum effective and the minimum toxic, there unfortunately is a high risk of overdose if we get things wrong, which obviously we try not to get those things. So once the drug has reached circulation, once it's exerted its effect on the receptor, once that concentration is reduced, then the body will go into the third stage of pharmacokinetics, which is metabolism. So metabolism sometimes is referred to as biotransformation, but basically it's the stage at which the body changes the medication or biotransforms it into a form that is not like itself. Now this is done first of all to make sure that it can't then go and react with other receptors, but also it allows the body to be able to recognize it as a waste product and therefore start to excrete it and ultimately get rid of it. So the most common site of metabolism is the liver, and hopefully as you know, the liver is a key site for all metabolism, a lot of processing of waste products, and it's essential for drug metabolism. So again, when we talked previously about disease status, we mentioned the kidneys, but the liver is also essential. So if our patient has a known liver condition, we do need to be aware that potentially their ability to metabolize medication could also be reduced. So again, the type of medication we use, we want to make sure that we use a drug that needs a very, very small dose, because what we don't want to do is give the liver more work than it can cope with, and again, potentially cause toxicity. So metabolism occurs through a two-stage metabolic process, and depending upon the medication that you're using will determine actually what's required. Now, all oral medications will go through phase 1 metabolism. So this is a process that unfortunately we can't avoid. The way that the body processes things that have come from the stomach is via the liver. So you will find that most oral medications will be affected in some way by phase 1 metabolism. So again, when we're picking our medications, we just need to be aware of that and potentially use a slightly higher concentration to allow for phase 1 metabolism. But what phase 1 metabolism does is the drug comes through to the liver, and then the liver releases specific enzymes which basically cause hydrolysis, reduction or oxidation. And what happens is the liver will depending on what type of medication we have, the liver will either steal the water molecules and destroy them from the medication, or it will actively oxidize. So create a reaction in the oxygen, which will then have the same effect. So it's basically trying to break the drug down from the inside out. Kind of think Independence Day with Will Smith. Hopefully you guys get that reference. But we're trying to attack the drug from the inside out, breaking the structure, and then causing it to break up into smaller pieces. And those smaller pieces are known as metabolites. So that's our first stage. For some medications, we then have to go through phase 2 metabolism. So they basically go back into circulation, get kind of retransported around the body, and they come back to the liver. And at this stage, we then have a slightly different approach. So they're still metabolites, they're still partial bits of medication, but at this stage, they're still seen as something that is hostile, something that is unacceptable to the excretion process. So what the body then does in this instance is it combines those medications with hydrophilic molecules, and that process is known as conjugation, and it basically attaches water-like substances around the metabolites, and suddenly makes it something that can be dissolved into water, which then means you can excrete it via routes such as through urine, which is obviously predominantly water. So once the medication has done that, we find that drug elimination occurs quite merrily. And in terms of drug elimination, there's a number of different sites that it can occur through. One of the most common is urine, and that would be through glomerular filtration via the kidneys. And as we said before, in most patients, this is an absolutely acceptable way of eliminating medications. But it's important for us to know the disease status of the patients, because, for example, as we said before, if we have, I don't know, a senior cat that has renal disease, and their filtration ability has already compromised, then we want to make sure that we don't give medications that are going to cause additional effort to the kidneys. We potentially want to give something that isn't eliminated via the kidneys, but if we don't have a choice, we want to make sure that we use a low dose, or we give additional hydration support so that we're not causing our kidneys to go into a state of exhaustion when they can't already do that. We've also got fecal elimination. So one of the key components of feces is actually bile. So the liver will process the metabolism and the metabolites, and those metabolites will be absorbed into the bile, and the bile is then reabsorbed into the large intestine, and the bile will be eliminated in feces. So that's really common. You can find that it's just absorbed back into the bile, and will be recirculated and neutralized. And then we've got a few slightly random ones. So saliva, some drugs will be eliminated via saliva. Another one is sebum, which at this point I'd ask if anyone knew what it was, but basically sebum is sweat. So it's released in sweat. And then the last one is milk. So this is why we need to be really careful when we're giving medications to pregnant animals, because what we can find is actually the medication metabolites are excreted in the milk, and then if the pregnant animal goes on to lactate, obviously pregnant animals shouldn't be lactating, but once the neonates are delivered, potentially the milk can present a direct distribution route for the metabolisms, and actually can go into the neonates and the offspring, and cause quite significant concerns. So when we talk about elimination, there's two different principles that we can apply, which give us some predictability around the elimination that we see. So the first of these is the elimination rate, which is basically the time taken for the drug to be completely eliminated from the body. And it's measured in milligrams per hours. And for each of our medication, there will be a concentration or a level that is deemed to be a risk of toxicity, and there will be kind of a safe area. And what we're trying to know is what is that time span for our patient to go beyond that toxicity into the safe area, and for the drug to be fully eliminated. And the reason why this is of interest to us, as I say, is particularly if we have an animal where there's increased risk of transmission through elimination, like we said, with our lactating females, but also with our food production animals, we need to be aware of how long this is going to take, so that we can assure ensure, sorry, that any byproducts that might enter the food system are eliminated before that food goes towards human consumption. The other factor that we can consider is known as the elimination half-life, and this is the time it takes for the concentration of the drug in the blood to decrease by 50% through metabolism and elimination. And this is slightly different because we're still anticipating that we will have some level of drug in circulation, but by 50%, the medication is deemed to be of low risk. And again, depending on the medication, sometimes the half-life takes a number of hours, a number of days, and again, it gives us an estimation of at which point the animal is at low risk of toxicity, but equally at which point we need to be careful about redosing, because potentially we could create quite a significant risk of toxicity or overdose. Okay, so if we were all together, this is probably the natural point that I would suggest that we have a break. So if you do want to pause the recording and go and grab a coffee, have a stretch of your legs, this would probably be a natural point to do so. For those of you that are staying, what we're going to do now is move on and start to think about psychopharmacology and how we use it, or how we can use it in the modification and control of undesirable behaviours in animal species. So in terms of what is psychopharmacology, hopefully the name gives some idea in that it's pharmacology, so it must be the study of drugs. And psychology, meaning that the study of mind, the study of conscious thought. And if we put the two together, basically it's the study of drugs that are used specifically to induce changes in the mood, conscious thought, and behaviour of an individual. So the way psychopharmacology works is the pharmacology that we administer, so the medication that we administer is designed to work on the endogenous or exogenous molecules within the body in order to change the observed behaviour of a specific individual animal. So when referring to endogenous, that means any molecule that is naturally occurring or naturally produced within the body, and exogenous would be anything that is received as information from the environment or is created in the environment and is absorbed into circulation. So in terms of what specific molecules we are considering, it's worth considering, first of all, which of our main body systems ultimately leads to the influence of behaviours that we observe. And again, apologies if you have covered this or if you haven't covered this, but in the most we would consider the neurological system as a key motivator of behaviour, and equally the endocrine system. So in terms of our specific molecules that we're considering, it would be any molecule that is involved in the transmission of neurological signalling and the interpretation of neurological signalling, and then any hormones or endocrine products that initiate hormonal changes. So first kind of question, and I guess this is the first thought for the day, is whether you think all animals behave the same. Now, an obvious answer would be no, but equally some of you might be thinking, in essence, yes. So it's not an easy answer to give one way or the other, and certainly we can look at individual species of animals and recognise a predictable repertoire of behaviour. So for example, if we were doing behavioural observations, let's say we were observing a dog, we would be able to generate a recognised ethogram of specific behaviours, so things that we would anticipate the animal to do or have the capacity to be able to perform. But having said that, whilst us as humans all have potentially the same ethogram potential, the reality is that we all respond in slightly different ways. So things like personality, personal preference, emotions, sensitivity all comes into effect. And obviously with animals, we also need to be aware of methods of learning that have been established, any associated behaviours, anything based on personal experiences. So whilst in some respects we can say all animals behave physiologically the same, often it's very difficult to predict actually what they're going to do in every circumstance. The other question is, do animals respond to fear and pain with the same degree of intensity? Now, if we were coming from this from a purely physiological point of view, which is what we're going to initially look at, again, your answer might be yes. They have the potential to feel pain. Certainly, a vertebrate species may well have the same organisation of the central nervous system. Whilst I appreciate there are variations in the anatomy of the brain, the fact that most of our vertebrate species, if not all, have a defined multi-structural brain, again, the potential there is, we could say, well, they have, again, the neurological capacity to be able to interpret pain. They have the sensory system available to gain information about what the stimulus is, and actually the response to that, whether it's something that is going to create a survival risk, whether it's something that is actually quite benevolent but is just causing discomfort. So it sounds like a bit of a funny thing to start with, but actually these questions have dictated for many, many years our overall response to particularly animal behaviour, but ultimately how we manage animal experiences, and also when we're faced with behaviours that are deemed to be problematic, how we respond to those. So the key thing to remember whenever we talk about pain, and often when we talk about behaviour, to be honest, is it's always an integrated process. So it's both physical and emotion. And unfortunately, we cannot measure emotion directly. Now, of course, for us as humans, we have a shared verbal communication method. We are able to talk, we are able to rationalise. You may well have found as a child that anytime you were angry or sad or happy, you were able to communicate those behaviours with your peers or with your family, but we don't have that same luxury with animals. Certainly, individual animals will demonstrate certain behaviours that we can recognise, but it does still make it difficult. So I know with my border collie that when she's painful, there are certain behaviours that I can expect. Normally, she's very elusive. She is an incredibly bonded dog, but she's also, I suspect, this is really bad, it's anthropomorphic, but I would suspect that she is an introvert. She doesn't particularly like to have that much time with us. She'll come and say hello, she'll come and have cuddles, but to be quite honest with you, her favourite spot at home is to sit in the chair and look out the window. And as long as she can look out the window and bark at the occasional cat and go crazy for the postman, her life is pretty happy for those periods of time that she's indoors. Now, when she's feeling unwell and when she's painful particularly, I find that she is my shadow. She's incredibly tactile, she's incredibly restless, she won't sit down, she won't settle, she doesn't really eat, and these are all behaviours that I have associated through experience that she demonstrates when she's painful or when she is anxious. But if I was to measure that, I'm faced with a really difficult challenge. I could say, well, let's measure how much food she hasn't eaten today, or let's measure how much time she's actually spent stuck to me. But the reality is even those are incredibly subjective. So whenever we talk about pain and behavioural changes, we need to be able to assess behaviour and physiological changes together. So actually, what is the pain or the stress leading to? What clinical parameters have actually changed? hopefully by now you've spent a bit of time looking at the autonomic nervous system, and again, apologies if you haven't, but hopefully you remember that it's split into two categories. So we've got the parasympathetic and the sympathetic nervous system, and it's the sympathetic nervous system that generates our proactive responses, so our increase in heart rate, our increase in blood pressure, our increase in respiratory rate, and all these functions are designed to encourage and support physical exertion. Now, that is essential if, for example, let's say I've got the border collie. She needs to run away from a big scary dog, or she needs to run away from a saber-toothed tiger. Now, we don't get saber-toothed tigers in Hampshire, but you understand my meaning. So the key thing there is that there is a physical threat that the animal needs to remove itself from. But sometimes we find that pain and fear and abnormal behaviours are associated with those kind of responses. So if the central nervous system has been if the autonomic nervous system has been activated, and specifically the sympathetic nervous system has been activated, then we've got physiological changes that we can measure. So with those questions in mind, the next challenge really comes for us when we try and discuss or predict how we're going to use medications to modify behaviours. And really the question that sits in front of us is, can we actually predict exactly how all drugs affect behaviour? Because as we said, behaviours often are individualised to individual animals, and particularly when we talk about behaviours associated with stress and pain and excitement, we generally anticipate that there is an emotional component to those behaviours. And as we said, emotions are very difficult to predict and are very difficult to objectify. So really the question is whether we can actually use drugs fully responsibly and in full knowledge of what's going to happen. Now, one of the arguments for the use of medication is the fact that the type of drugs we use specifically, which are known as psychoactive drugs, interact with very specific target sites, and those target sites are found within the nervous system and will generate very specific physiological or psychological responses. So the argument is actually, whilst there is some difference between the manifested behaviours, the actual physiology, based on the functionality and the species specific ability, should allow us to have at least some level of prediction. So whenever we use medications, we've kind of got two basic functions that we're considering. So we can either encourage an excitation function, meaning that we are agonizing naturally occurring neurological stimulation or neurological pathways, and we're actively trying to extend or enhance the physiology that is occurring. Or we can use an inhibition function, where we antagonize a naturally occurring process. And within our inhibition process, it allows for the suppression or the decrease of certain behaviours, which in some instances might be deemed problematic. So from now on, we're going to talk about some problematic behaviours and how medications can be used, and particularly the literature surrounding the use of these medications. But I just want to be clear, when we define problematic behaviours, these behaviours are deemed problematic by human perception. So realistically, none of these behaviours are abnormal. They are all normal functioning, normal in their response. They're all things that are part of the animal's behavioural repertoire. But unfortunately, the premise or the situation in which they're presented are often deemed undesirable by the owner themselves. So just bear that in mind whenever we talk about the ethics of medication use, that often the motivation is to allow the animal to become more accustomed, or to conform a little bit more with the owner's expectation of what is deemed acceptable within a companion environment. So generally we find two specific drug areas and two specific drug actions. So the first is drugs that work on neurotransmitters. So what we're trying to do is modify synaptic transmission, so the part of the neuron that specifically controls distribution and particularly the spread of neurons from one neuron through its dendrites to the next. And then we talk about hormones as well. So hormones are really, really important in the communication between cells and often in response to neurotransmitters. So depending on upon the behaviour that we are trying to manipulate will determine the precise location of the drug action that we perform. But depending upon the actual category of drug action will also determine the type of intensity or the type of response that we are able to establish. And often we find with hormones, for example, because of their very nature, they tend to be more diffuse they tend to be more likely to diffuse. They have a much longer effect on the body. So therefore the drugs that we use potentially are going to be more invasive in order to get the desirable effect. So in terms of the nervous system then, the key thing to remember is most of the time our adaptive behaviours depend very, very closely on the interactions that we observe between the body, the environment and the received information to the nervous system. So whenever we talk about different species, one of the things that is worth considering is whether the stimuli are considered as critical and therefore are received in their purest form, or whether we are getting a stimuli based on a filtering of sensory input. So obviously remember you have your special senses, so sight, hearing, taste, smell, but you also have your pure neurological touch stimulation as well. And depending upon the intensity of those stimuli would often determine the type of response we see, but equally every single stimuli will be processed and interpreted by the brain, and ultimately that's what determines the perception and the physical response to those stimuli. We certainly have some species that have evolved to only filter and only respond to stimuli that are deemed to be abnormal, and often this is commonly seen in a lot of our prey species. And I have to be honest, there's plenty of species that until I read research, I had completely underestimated. So one example from research, it's quite old research now, but found that leopard frogs have the ability to basically switch off their visual organs simply by recognition of whether something is abnormal or is normal. So they actually only respond to stimuli that are deemed to be critical or deemed to be a threat to them as a species. I'll try and find the paper for you because it's quite an interesting paper, but it just shows that actually whilst we assume that the nervous system is fully aware and is fully conscious all the time, we have got some species that have developed adaptive behaviours purely by their ability to filter and interpret the information they receive. So in terms of what chemicals influence nervous transmission, hopefully the answer that you were thinking of is neurotransmitters. So this is a huge range of different neurotransmitters that are in existence in the neurological system. And as I said before, what we're trying to establish is whether we need to encourage or excite the neurotransmitters to try and increase the prevalence of them in the blood system, or whether in some situations we actually need to dampen or inhibit their action in order to be able to reduce or suppress certain behaviours that we witness. So whenever we talk about neurotransmitters, the potential is that these drugs that we use have the ability to modify more than one part of the synapse. Now, it might have been a little while since you remember your synapses. We have got a slide coming up that will just revise it for you. But the key thing to remember is, again, depending upon the neurotransmitter and depending on the drug action specifically, we can act on any number of parts of the synapse transmission. So what we can do is we can stimulate chemicals that are precursors or kind of loading chemicals that will encourage the neurotransmission release. We can inhibit the synthesis of the neurotransmitter, so ultimately we can help to prevent behaviours from occurring by stopping a lot of the signalling chemicals that are actually required in order for a behaviour to even commence. We can prevent the storage of specific neurotransmitters, so we can reduce the sensitivity of the neurological system, its ability to react and respond to its environment. We can also help to, we can try and stimulate or inhibit the actual release of the neurotransmitter. So not just the storage, but whether or not the vesicles that contain the neurotransmitter, whether they are actually going to be able to release the transmit the neurotransmitter that they've actually created. We can also look at the postsynaptic receptors. So with our synapse, we always have a start and a finish point, and those synapses will sit at the end of the corresponding dendrites or from the neuron. So again, we can try to prevent the message from entering the next dendrite on the next neuron. So again, that's something else that we can do, that maybe we can't block the stimulation and we can't block the neurological activity, but we can control or activate the response or the ability of the body to then continue that signaling. We can also inhibit the neurotransmitter from being released, as we said, but we can actually work on autoreceptors, which are specific receptors that will respond and release neurotransmitters automatically. And another thing we can do is we can actually inhibit the breakdown of the neurotransmitter. So actually encourage or enhance the neurotransmitter activity simply by preventing their breakdown into. So as I said, for those of you that need a little bit of recap, this is our synapse. Hopefully it looks semi-familiar. And as we can see, this is the end. This is one of our synapses, which is our presynaptic cleft. And this would sit at the end of the neuron on our dendrites, so our finger-like structures. And the key thing here is that we've got this synaptic cleft. So there's a gap between our two synapses and our two parts of the neuron. And what the neurotransmitter will do is through exocytosis, it will basically open up all of these little vesicles and release neurotransmitter as the electrical signal comes up and through the synapse. Now, what the neurotransmitter does is it acts as almost like stepping stones and helps to facilitate the movement of the neurotransmission. So really, really effective. And then the other side, we've got our receptors that will receive the neurotransmitter and allow the synapse to reset and allow another signal to go through. Okay, so the next molecule then that's of interest to us when we're trying to modify behaviour would be hormones. So hormones work in a very different approach to our neurological signalling. So our neurological signalling and our neurotransmitters are confined to our neurological system or our nervous system, whereas hormones have the potential to be released into many, many systems within the body. And have a much more systemic effect, meaning that once they're released, they can spread very easily within a specific system and have almost a whole body effect depending on the hormone that is released. So what we find with our drugs that we're using between hormones, the important thing is that they have a quite systemic effect, because we know that hormones move throughout body systems and have a much more sustained effect, whereas our neurological signalling, as I said, tends to be focused to a very localized area. And whilst the behavior that we observe can be very generalized, it's very easy to target the response to a specific area or to a specific stimulus. So whenever we talk about hormones, again, the drugs we use work in a number of different ways, but in the most we can categorize them as modifying the secretion of hormones. So again, some drugs we use will encourage hormones to be released, some will inhibit them. We can also use the drugs to actually change the behavioural responses that we witness. We can also use them to stimulate the psychoactive properties of the hormones, and also encourage further hormones to be released. Because remember, for some of our hormones, they act as catalysts or precursors, and they are simply required to stimulate the next part of the process. So, for example, in the release of cortisol, which I'm sure you all know what cortisol is, we have the HPA axis. So we have a clear sequential process of one hormone being released, followed by another one before our cortisol is then released. And whilst it might be our cortisol that results in our kind of observed behaviours, the key thing is that unless we have the release of the previous hormones by the hypothalamus and the pituitary gland, we're simply not going to see the release of cortisol in the same way. So the question then about how hormones and behaviour works, well, in terms of hormone-induced behaviour, we find that the endocrine has a much slower response because it generally is secondary to the neurological system. And as a result, we find that the effects, as we say, are much more gradual and much more systemic. So whereas our nerve impulses, as we said, tend to be focused to a specific area, or they may be used to stimulate a specific muscle that we need to initiate. Potentially our neurological system, for example, if we find that our sympathetic nervous system is activated, then we're going to get a very specific physiological response. So whether that's increased heart rate or increased respiration rate, utilization of glucose, for example, it's very, very targeted, it's very, very specific. Now, the challenge with our hormones is because they are slower and they are much, much more widespread, we find that the influence of the endocrine system is much more sustained and often becomes quite difficult to kind of switch off almost immediately. So any behaviours that we see that result from hormone imbalances or the release of specific hormones generally will take quite a lot of unpicking, and we need to set the expectation that these behaviours are going to take some time before we start seeing a change in the behaviour. The other thing that's important to remember is our hormone system or endocrine responses are very closely associated with our environmental stimuli. And again, this is really, really important when we're trying to consider behavioural stimulants or triggers for specific things we see. So, for example, circadian rhythms, which is length of daylight, we know that hormonal patterns change quite significantly. Even something like a chicken and their reproductive ability is very much seasonal. So we actually have chickens at home, and it's about this time of year that the laying frequency drops quite significantly. Now, it's probably not a surprise that because we are hobby chicken owners, we don't create artificial environments. We don't keep them in constantly lit enclosures. They are very much subjected in the sense of they are free range chickens, so they have access to the natural environment. So their hormonal patterns are very much subjected to the length of daylight, hence why at the moment we haven't got a huge amount of egg production. Okay, so as we said, we've got a number of different triggers that could be the source for behaviour. It could be a neurological stimulus, it could be an endocrine response, it could be a combination of the two. And potentially we're now in a position where we have decided we want to try and modify that behaviour. Maybe we've got an owner that's come to us that is concerned about particular behaviours that they're witnessing. Maybe it's becoming problematic. Maybe it's becoming a little bit unsociable. Maybe we need to apply an ASBO to a particular animal. I'm joking, by the way. But the key thing is that you've got this behaviour that for whatever reason you're trying to modify. Now, before you go any further, and this is what we would always do in veterinary practice, is we need to perform a clinical assessment. Because it's essential, first of all, that we understand and confirm what is the behaviour, but equally from a responsibility point of view, it's quite unethical of us to administer a medication to an animal that doesn't have the physiological ability to be able to metabolise it and excrete it, as we said before. So we would always perform a clinical assessment, and in most cases this will start with blood analysis. So we perform a routine hematology assessment, which basically looks at the structure of the blood, looks for the presence of white blood cells, the overall health and number of the red blood cells, looks to see what platelets are, etc. And then we would perform a biochemical assessment, which basically looks to see what chemicals, what compounds are in the blood. And again, this is going to give us indication of our current patient's status, if there's any dehydration that we're concerned about, if there's any underlying health concerns. And from a kind of pharmacology point of view, one of the key tests that we do need to perform is an assessment of current hepatic and renal health. So our liver and our kidneys. And as we said before, this is essential to make sure that we are responsibly prescribing medication. Now, just to point out at this stage, the prescription stage is a vet-only responsibility. And myself as a veterinary nurse, I do not have legal rights to prescribe medications. So from my kind of position, I would be assisting in the clinical assessment, potentially running the blood sample, hopefully taking the blood. But the actual prescription of the medication is not a responsibility that I have. So, for example, if some of you are considering going into behavioural assessment or behavioural consultation, it will be the same for you, that anytime you wish to use a medication that has a prescription only status held over it, for safety reasons, for example, for their licensing reasons, then you would always need to go through a MRCBS registered veterinary surgeon, so that they have been accredited with the RCVS. The other thing that's worth considering is we do need to monitor cardiac function. The reason for this is a lot of the medications that we are going to consider do have a significant effect on the nervous system and the endocrine system. So as we said before, we may well be using something that is going to inhibit specific neurotransmission. And just bear in mind that for some of these conditions, if the patient has got an underlying heart condition, we're ultimately, or have the potential to change heart function. So again, if our patient has, for example, congestive heart failure, it would be quite irresponsible of us to give a medication that's going to cause a sympathetic nervous system stimulus, because what that's going to do is increase the heart rate, increase the respiration rate, and increase the blood pressure, which ultimately could put quite a significant strain on the cardiovascular system. So again, we would always do a preliminary assessment of cardiac function. The other thing that's really important with our clinical assessment is it does give us that chance to try and assess whether there is an underlying condition that may be responsible for that particular behaviour. So let's say, for example, our owner has come into us that they have a cat that has just started urinating around the house and appears to be marking and spraying quite a lot indoors. And unfortunately, cat urine is not the nicest smell, and it's becoming quite a deterrent to their friends and family. So whilst urine spraying and territory marking is a genuine behaviour, and as we said before, it's a perfectly normal behaviour, but for some owners it is deemed quite problematic. Excessive urine spraying, or particularly polyuria, which is increased urination, is also a clinical sign of cystitis. So it may well be that yes, the cat is urinating, but potentially it's actually got quite an inflamed bladder, and that's what's causing it to urinate, because it's actually really uncomfortable and really painful. So again, it's really, really important before we start prescribing medication that we just try and see if there's any other reason that we can contribute to the behaviour before we start giving medication. The other thing to bear in mind is whether or not the animal's current condition or current health status is ultimately going to influence our choice to use medication, and also what kind of medications we can use. So as I said before, if the animal has an underlying health concern or potentially has an abnormality that's already been diagnosed, again, we do not want to give a medication that's going to exacerbate that or cause further progression of an existing clinical condition. So again, it's just being slightly mindful of the patient's current status and making decisions based upon that. The other thing that our clinical assessment provides is a baseline. So whenever we consider our kind of objective or our clinical parameters, what we would consider is a baseline. So basically it's a snapshot of the patient's current health status the moment before we start using medication. And we do this in every single situation where we're prescribing long-term medication. And basically what we do is we want to monitor this patient every 6 months to see how their clinical parameters have changed, to ensure that we don't cause any ill health or what's called anthropogenic concerns, so human caused or treatment caused side effects that actually could be detrimental to the patient's health. So again, from a responsible point of view, we want to be doing every 6 months blood tests, again repeating our hematology and our biochemistry screens just to see if there's been any adverse or any significant changes to the patient's condition. The other thing we want to think about is the patient's current health status in terms of their age. So whilst age might be an influence to their behaviour, it's also important to consider how their age is affecting their overall health status. So for example, with our older patients, and this would generally be anything that is considered geriatric, and an animal is considered geriatric when they enter the final third of their life expectancy. We generally find that they have a much slower metabolism, so they are generally able to process medication at a much slower rate, and also might find that certain hormonal changes specifically have a more systemic effect and a much longer acting effect, because the metabolism is going to be more delayed in its ability to process and excrete a medication. We also find that our older patients tend to have age-related debilitation of their vital organs. So again, here we'll be looking at our liver and kidney function, and also unfortunately there is a higher chance of underlying health issues in our older patients. So again, those are all things that we would need to consider before we start prescribing medication. Now, for our younger patients, it's almost the other end of the spectrum. So whilst we might find that younger patients are performing problematic behaviours, and for any of you that have had young animals before, often it feels like they are showing lots of problematic behaviour. I know when my collie Moo was a puppy, there were quite a lot of behaviours which initially were seen as problematic or undesirable. And I suppose the one question could have been, is there a medication we can use that would calm her down? She was very much a typical collie, very lively, slightly mouthy, lots of vocalization, lots of curiosity, lots of really lovely behaviours, like she had very much an interest in eating feces, but equally a lot of those kind of sides of her behaviour were developmental. Equally, I was still in the stage of training her. So one of the questions is this behaviour something that is established, or is it purely that it's through learning and association that this puppy ultimately is demonstrating these behaviours? So that's the first thing to ask yourself, is actually, is this a behaviour that has the risk of sustaining? Is it something that is going to be an ongoing concern? The other question is, really, if this is a sustained problem, is it ethical for us to use long-term drug use, and is it sustainable? Now, those kind of questions come from a couple of different areas. The first, and should always be the priority, is from an animal welfare point of view. So again, is it fair for us to require an animal to take a tablet, let's say every day for the rest of its life, which potentially it doesn't want to take, or at the very least it will tolerate to be taken? Does it have side effects? Does it have potential adverse effects? Is it going to inhibit their behaviour for the rest of their life? Again, it's questionable whether we should be using these types of treatment. The other kind of sustainable side of things is obviously everything comes at a cost. And one of the things that we often discuss with owners is the expectation of their commitment to the problem, let's say. And owners need to be made fully aware at the beginning of how long a treatment is going to be required for. And this again is part of our professional conduct requirements, that all owners are given the opportunity to be made fully aware of options, and that there is a choice involved in it before they give informed consent. And it is the same with our behavioural modification programs, that owners need to be fully aware of potential financial costs and time costs, so again they can make an informed decision. In terms of general health assessment, as we said before, also think about other health conditions, but also, as we mentioned when we talked about pharmacodynamics, the important thing to remember and consider is what other drugs are they taking, and is there potential for any interactions to occur. Now, again, from this side of things, we may well be considering our adversive effects, and actually, again, from a responsibility point of view, we need to consider these. Again, it's wrong of us to give a medication on top of a medication if we know that it's going to cause ill health to the patient. But equally, just being aware of other, as I say, less concerning interactions. So again, is there a summation effect? Could we cause synergism, for example? So it's all things that we need to consider before we rush into giving a medication. Okay, so we're into the last third of our lecture, and again, this is quite a natural point if anyone wants to go and have a 10-minute break or pause for a coffee. So for you, those of you that are continuing to join us, what we're going to do for the last third of the lecture is to talk about a few different examples of medications that are currently available and that are currently licensed in some instances, but also used off license in the modification of a specific behaviour. Now, it's worth mentioning at this stage that in the UK we have specific licensing guidelines and specific licensing regulations, and basically in order for a medication to be considered licensed, it has to have gone through a very rigid and very specific testing process, which basically proves that that medication is effective in the treatment of the condition that it is prescribed for, but also that it is effective and safe in the species that it is intended for. Now, in order for that to be performed, I'll say there is a repeated requirement for testing, and that generates a level of predictability in the use of that medication. So once that's been established, a medication is given a specific license which allows us to use it for that specific condition in that specific animal. Now, a number of these medications that we're going to talk about this morning are actually used off license. So what that means is there is not a suitable medication currently available in the license list, let's say, and what a veterinary surgeon can do is select other medications which have a desirable effect that may not yet be licensed in the specific species. So that is performed under what's called the cascade system, which is outlined by the veterinary medicines regulations, and there is a clear process to that. So even if we are using off-license medications, veterinary surgeons are required to follow a process that basically proves to the RCVS and the VMD, so the Veterinary Medicines Directorate, which are two of our governing bodies, proves that there is a clinical justification for the medications that have been selected. So, number of different medications here. Some of them are licensed, some of them are off license. And what we're going to do now is just go through a couple of different examples of medications we can use. And I've also got a number of papers for you to consider. Now, I will share these papers with Lisa, so again, if you wish to go back and have a look at them, I'm sure that Lisa wouldn't mind putting them up on Canvas for you. What I would say with some of these papers is they are isolated studies, so again, do some background reading, look at the references, look at the population, and see what you think, basically. So the first category that we use quite prolifically actually in veterinary medicine are tranquilizers and sedatives. And there's lots of different categories of tranquilizers and sedatives, but basically what these do is they encourage the animal to feel lethargic and at the extreme actually be completely asleep. And often these medications are seen as a really valuable way of reducing an animal's sensitivity to fears and phobias specifically. But we also use them in animals that show quite specific aggression, or that show quite erratic behaviour in certain environments. So one category that we use is known as a benzodiazepine. So benzodiazepines include lots of different medications, but one of the medications that hopefully you've heard of is diazepam. So diazepam is a really beneficial medication because it has a number of different effects. So it will allow your patient to be sedated. It will cause muscle relaxation, which from an animal that is experiencing noise phobia, for example, which we've just come out of, fortunately actually, we've just come out of fireworks season. Unfortunately, we've just had it. And a number of dogs who have extreme noise phobia, I suspect would have been prescribed diazepam at some point in that period, because what it does is it allows the animal to basically fall asleep, makes them feel very relaxed, very calm, and helps to avoid or limit their perception of the external stimuli that is of concern to them. The other thing that benzodiazepine does, which is particularly valuable, is it has an amnesic effect. So historically, there are a number of medications we used that provided sedative and muscle relaxation, but they didn't have this amnesic effect. So basically, your animal could potentially be aware of the trigger, wouldn't be able to respond to it, wouldn't be able to necessarily move, but actually the memory part of their brain was still active. So rather than allowing the animal to become unaware of the surroundings and actually have quite a blissful snooze, what you'd find is actually you'd still have the potential to build up association. And in some animals, it was actually seen to have quite a traumatic effect because they weren't able to physically remove themselves from the stimulus, yet they were fully aware of it. And actually that was seen to be quite quite disadvantaging to the animal. So benzodiazepines allows for that amnesia, and this is why we often use it quite extensively. And the way it works is it facilitates the action of the gamma aminobutyric acid, which is basically an inhibitor neurotransmitter in the central nervous system. So that's how it establishes sedative qualities and muscle relaxation, is it directly inhibits the stimulus of the neurological system and prevents the transportation of information to the brain about the specific triggers. So rather than the animal being fully aware and reactive to particular triggers or to its environment, it causes the animal to become asleep, forces the animal to go to sleep, because the neurological signalling is not being transmitted. I've just popped in there the antagonist, because it's always worth knowing if you have got almost like an antidote to these medications. So I just put those at the bottom of the page because, again, obviously there can be situations where animals respond adversely to medications, or we haven't quite got the dosing right. So it's always worth knowing what the antagonist is. So I mentioned before about historic medication. One of the medications that we did use quite prolifically is acetramazine, otherwise known as ACP. It's still used quite extensively in pre-medication, so the medication we give to an animal prior to general anaesthesia to start the sedative process. But as I say, this particular medication doesn't have the amnesic effects that benzodiazepine does, but what it does is it blocks the dopamine and the serotonin receptors, again, which are required for responsiveness and awareness, which is really key in an animal's ability to perceive its environments. Okay, so another category that often we use in veterinary practice for, to be honest, for other purposes, but that can be used for behavioural modification, is where we use neuroleptal analgesics or neurolepto anaesthetics. So these would be an example of a synergistic interaction, which is where we use a sedative and an opioid. So your sedative is your neurolepto agent, so it causes sedation, as the name suggests, and lowers an animal's ability to perceive and interpret its surroundings. And then the opioid gives quite significant analgesic effects. So there's a number of different drugs that we can use, but commonly in practice we would use ACP and buprenorphine. So ACP is our sedative, as we said already, And buprenorphine is our opioid. For a slightly stronger analgesic effect, we also have the option to use methadone, but this would be considered our pre-medicant. Now, we do have other medications we can use, and again, fentanyl is currently quite a preferred analgesic agent, but it's also worth considering actually how much analgesia we actually require, because for some of these medications, whilst they provide a really nice sedative and quite a synergistic sedative effect, for some of our patients they simply do not need the analgesia. So again, that's going to dictate the type of medication that we select. In terms of the qualities, so it gives us about 30 minutes sedation with analgesic effect, and the reason why we commonly use them in practice is it allows our patients that are showing specifically anxiety or hypersensitivity to the environment to basically be given the opportunity to have a period of relaxation and a period of less sensitivity. It's worth mentioning though that ACP by itself is not a tranquilizer. So as we said before, it will not cause amnesic effects and it will not affect memory. So again, it needs to be given in combination with another medication. So next category that we're seeing is being used quite prolifically in behavioural management is our monoamine oxidase inhibitor. So this is a medication that specifically affects the activity of monoamine oxidase, and what we find is it actually prevents the breakdown of the neurotransmitters. So the monoamine enzyme is designed to break down the neurotransmitter, but because that has been inhibited, it's not available to be able to do that. So monoamine oxidase inhibitors are used predominantly as antidepressants, and because we're using them to increase the presence of neurotransmitters, we generally find that they enhance mood and they enhance responsiveness to an environment, because you're basically giving increased availability to the neurotransmission and to the overall neurological system. But the key thing is that there are two forms of monoamine oxidase. So they both have slightly different functions and slightly different effects. So there's so I'm going to abbreviate here, MAOA and MAOB. So whenever we talk about the medication, it's key that we understand what isoform we are actually using. So in terms of why that's interesting to us, so a MAOA inhibitor product will help to prevent the breakdown of serotonin and norepinephrine and dopamine, and we also find that it is a selective inhibitor of tyramine. So all three of these neurotransmitters are really quite key in enhancing mood and increasing activity levels in an animal, and that's why we find that they have a significant effect in the reduction of depression and help to improve mood and generally enhance mood. But it is worth saying that they have to be used with specifically our MAO inhibitor. We need to be really careful when we use it because it has got the potential to actually cause serotonin syndrome, which unfortunately it's unreversible and can actually cause the death of the animal. Again, I will leave you to have a read up around that if it's something you want to look into further. And in terms of our tyramine, tyramine again is a mood enhancing neurotransmitter, and we find that actually there is a risk of build-up if it's not used appropriately. So again, we need to monitor our in those animals. So I've got a nice paper here for you that looked at the use of inhibitors specifically in mice, and in this paper it considered both isoforms. So the mice were given the medication, and the paper suggests that it seemed to, or it was at least indicated, to have an effect on stress, obsessive behaviours and social phobias. I'm always slightly intrigued and again, this is my ignorance, how you identify social phobias in a rat. I understand that they are incredibly intelligent, but I'm not, to be honest, I'm not sure of the actual observation process. If anybody does know, again, feel free to email me. But what they found is actually animals that were in a position where they had the medication, they seem to be more resilient or have increased resistance to the presence of environmental stressors. So it was seen that actually in the presence of these medications, animals seem to have some impairment to potential stressors or things that the humans had assumed would cause stress to the rats the mice. I keep saying they're rats, they're mice, but to the mice specifically, which was seen to be quite a advantageous effect, particularly in animals that were deemed to have high levels of anxiety. The thing that was quite interesting, though, with this particular paper is they weren't able to identify additional stressors that maybe had led the mice to demonstrate compensatory or adaptive behaviours. So whilst the paper did suggest that the use of MO inhibitors definitely had a place in the treatment of individual anxiety, it was difficult to know actually what the sophistication was of the triggers, and whether it was the reduction was specifically due to therapeutic effects or whether there were other things that had been noted. Certainly oxidative stress, so the physiological stress, was seen to be reducing, but again it was unclear of the main source of that. So next medication to mention then is fluoxetine. I suspect this is something that you have heard of, otherwise known as Prozac. And fluoxetine has become quite popular with a number of our patients actually being on it. There was a bit of craze a few years ago where lots of cats specifically were placed on Prozac, and actually the veterinary press and the public, kind of more general public press, did pick up on it. So again, if you kind of Google cats on Prozac, you will find that there is quite a lot of papers there. So fluoxetine is a selective serotonin reuptake inhibitor, which basically means that it allows for the circulating volume of serotonin to be kept at a more established level. And it is seen to be a really effective treatment choice for lick dermatitis. So this is in instances where animals, particularly dogs, have a compulsion to lick and chew their feet. And in terms of the psychology behind it, it is seen to be caused by a similar psychological process as OCD in humans, that there is an active compulsion associated with the desire to lick and self-groom, and in some animals that was exacerbated to the level that they will actually self-traumatize. So it is a common medication that's used. As I say, it is widely available, but the key thing again that's a little bit concerning is it can actually cause quite significant malfunctions to the serotonin neural mechanisms. So again, it's not to be used without the consideration of possible side effects. But again, in terms of what other medications or mechanisms could it affect, again, it could have lots of other more wide concerns. So quite an interesting paper for you here. Again, apologies for the date of it, but what it looked at specifically was the presence of behavioural changes after fluoxetine use. And in this particular paper, what they were looking at were kind of assertive or excitation established behaviours that were seen to be undesirable. So specifically dominance behaviour, as I say, assertiveness, territorial aggression, excitability and fearfulness. So behaviours that were seen to be quite extreme and seem to have a very specific trigger. So whilst the paper looked at a wide range of behaviours, what was quite interesting is that the behaviours were actually seen to have very little effect were seen to have be very littly affected, in the presence of fluoxetine. So what was interesting is actually a lot of the animals that were on fluoxetine were seen to actually have quite a high level of irritability, and in some cases were seen to have slightly worse aggression than they had when they were previously on fluoxetine. The other thing that's interesting with this paper is it used a lot of owner perceptions excuse me, as a means of assessing actually what the perceived change was. Now, obviously, whilst owners are really, really valuable and it's a perfectly acceptable sampling method, it does open the potential up for the population to have quite a biased interpretation, particularly for owners that have been struggling with problematic behaviour for some time. And there is the potential that actually it's more of a placebo effect, in that owners were really, really keen for there to be an improvement, and therefore not necessarily misreported, but that it did overall influence their perception of the animal's behaviours. So next one we've got then is clomipramine. So this is the only licensed product that we are considering currently, and it's used specifically in canine behavioural problems. So it's been tested and approved in dogs specifically, and it's used for separation anxiety, excessive barking, and destructive behaviour. It's also been seen, and this is not yet licensed, but there has also been seen to be positive effects in the reduction of abnormal or problematic behaviours in cats, specifically urine spraying, compulsive behaviours, and aggression. So clomipramine as a medication is a tricyclic antidepressant. So again, it works to establish neurotransmitters, and the idea is that actually in some instances you can, if you encourage more of a stabilization, you can help to remove behaviors. But what's worth mentioning is that cats, whilst it's currently being tested and it is used off license, do tend to demonstrate quite a high level of hypersensitivity, so actually seem to become more erratic in their behaviour in the presence of clomipramine. So another paper for you here, this is a much more recent one from 2017, but it looked specifically at the presence of tail self-mutilation within domestic cats, and the thing that is worth noting at the beginning is that this particular behaviour was unclear of its trigger, and actually the authors recognised the fact that it was quite difficult to identify whether the behaviour was stemming from motivation of self-mutilation or whether it's purely over-grooming, and with that in mind, both of them have compulsive associations with them. Both of them seem to be led by a repeated activity or a compulsion to do that, which is often the reason why animals are seen to actually have the potential to self-mutilate, because actually they just do the repeated behaviour over and over again, and don't necessarily associate it as something that is going to cause them harm. You may well have little things that you do. I know I get told off for I tend to be a bit of a nervous picker of my fingers, and often I don't realise I'm doing it. So the idea, if it is a compulsive disorder, again, may indicate why the animal doesn't have kind of a self-regulation process in place. So what's interesting with this paper is, first of all, again, they identify that the actual pathology of the behaviour is not clear, but there seemed to be some positive response to alterations in the neurotransmitters. So as I say, whilst the pathology was unclear, the physiological effects seem to have some kind of benefit. But again, this is quite a nice paper, because what it does establish is that, again, there's not one specific reason for specific behaviours to occur, and what this paper recognised was actually the presence of environmental changes and overall kind of behavioural modifications. So it was seen that actually in some cases where cats were seen to overgroom, which often cats will overgroom as a sign of anxiety or a sign of existing phobias, in some situations, the environment was changed. The cats were given more privacy, were given more climbing areas, potentially were given more resources, as well as having established behavioural modification and retraining programs. And overall, it was then seen to facilitate the success of the medication. So read into that what you will, but overall, it was seen as quite an effective addition to behavioural modification. Okay, hopefully you're still with me, but another one that's worth mentioning is gabapentin. So gabapentin is an interesting medication in the fact that it's actually an anticonvulsant human agent, and that's what it was originally developed and licensed for. But it's used a lot in animals currently for neuropathic pain, so meaning pain that originates from the neurological system specifically, rather than, for example, muscular or visceral pain from body tissues. So it's becoming something that is being used quite prolifically off license in a lot of our companion species, but equally it's being investigated quite heavily in humans. And gabapentin works on a very different mechanism. So whereas the other medications worked to prevent the transmission or the increase of neurotransmitters, what gabapentin does is it works to block calcium channels within the neuron specifically, which basically causes the neuron to go into a state of freezing. So it hyperpolarizes it. It prevents its ability to reset and re-receive information. So it works on a slightly different process. As I say, it's unlicensed currently, but it's becoming, or it is, a very commonplace medication that we use in veterinary practice. Okay, so another one just to mention is the beta blocker, and again we use it quite prolifically in human and animal medicine, and what it does is it acts as a protein binder for adrenaline and noradrenaline. So again, it inhibits the transmission and activity of two quite significant excitation or kind of reactive neurotransmitters. So the reason why we use beta blockers is they have a direct ability to inhibit the sympathetic nervous system. So with our a lot of our behaviors, we know that some of them are triggered by the initiation of the sympathetic nervous system. So increased heart rate, increased contraction of the ventricles specifically, and increased conduction of electrical impulses to the AV node. So basically it will cause your animal to be quite reactive and have the potential to respond and behave in a particular way to stimuluses. So what beta blockers do is they will inhibit the beta 1 receptors, which basically will have a key role in the transmission of adrenaline and noradrenaline. So instead of being highly reactive, our patients become or are inhibited in their sympathetic nervous system. So we find that it causes a reduction in heart rate, a reduction in contraction, and a reduction in conduction of electrical impulses. So therefore that minimises their responsiveness and makes them a lot less likely to be able to initiate the fight or flight response, which, as we said before, is critical in the release of cortisol and the manifestation of a number of kind of stress-induced or reactive behaviours. So we've got quite a nice paper here from Mills, 2005, which looked at the use of propranolol, which is a first generation beta blocker. And what it did is it assessed the presence of autonomic responses of stress in canine patients suffering from noise phobia. So noise phobia, as we said, would be a specific trigger that is more than likely to initiate the sympathetic nervous system, and it's that kind of sense of impending doom that we often associate with phobias, and that's the reason why the actual inhibition of the sympathetic nervous system was seen to be quite beneficial. So the key thing here is it was seen to block the sympathetic nervous system and actually help the owner or the trainer in eliminating reinforced behaviours. So rather than the animal experiencing or hearing a trigger and the symptomatic nervous system kicking in, which basically is going to prepare the animal for physical exertion or impending doom. What we find is actually it made the animal feel much calmer, and often reduce that association. One of the challenges with phobias is often the sympathetic nervous system kicks in, but unfortunately the trigger required to switch it off is never really there, because it's the potential fear of things that are going to happen, or an associated fear with something, and often you find that there's not the actual response that's required to switch everything off. So that's why phobias can be particularly problematic in animals, because it will encourage the release of cortisol, but the actual response that the animal was expecting never happens. So therefore the body never goes back into homeostasis, which is just another point. So it was found that actually propranolol by itself was quite effective, but it was even more effective when it was used in combination with phenobarbital. Phenobarbital is a further form of a sedation, so again we've got a synergistic effect occurring here. It was also seen to be most effective for behaviours that had a recent onset or were sporadic. So basically behaviours where there seemed to be less association and less prior learning were seen to be most effective. So it was almost like you could, anything where there was an element of surprise, let's say, was seen to be more appropriate. Okay, and with that, we are at the end of this morning's lecture. So again, if I was with you, I would give you opportunity for any questions. And it's quite sad that I'm not, because often this is a point where we can have quite a nice discussion. Having said that, as I mentioned at the beginning, I am more than happy for you to email any specific questions that you might have for me. So if you do want my email, please ask Lisa, and I'm sure she'd be more than happy to share it with you. Equally, I have shared all the journals and links to journals that we've discussed in today's lecture. So I would encourage you to go away and have a look at those, particularly when we talk about kind of the use of behavioural modification. It is important that you spend time looking at the research yourself, because often there are quite a few ethical discussions surrounding behavioural modification. Hopefully today's lecture has given you a flavour of some of the uses and some of the clinical justifications for them. But as I say, if you have got any questions, feel free to email me. It is worth saying at this stage, as I mentioned at the beginning, I am a registered veterinary nurse, so I'm only ever really coming from this from a kind of research discussion point of view. If you do have specific behavioural questions, please do refer to a qualified veterinary surgeon or a clinical behaviourist. Otherwise, I hope you have a lovely weekend, and I wish you every luck in your studies. Thank you.